Hello, brilliant nursing minds. Welcome once again to Stancoast NCLEX, your trusted companion in mastering nursing concepts with confidence and clarity. Here, we post 2 to 3 advanced NCLEX videos every single day, each designed to strengthen your knowledge, enhance your critical thinking, and prepare you for both the exam and real-life clinical excellence. In today's hematologic-focused session, we are exploring one of the most vital and high-yield topics: nursing care of clients with bone marrow disorders. Bone marrow is the body's factory for producing blood cells, and when it fails, every system feels the impact. In this lesson, we will uncover the pathophysiology, manifestations, and management of key bone marrow disorders such as aplastic anemia, leukemia, myelodysplastic syndrome, and bone marrow suppression due to chemotherapy or radiation. You will also learn critical nursing interventions related to infection prevention, bleeding precautions, nutritional support, and post-bone marrow transplant care. Each concept is presented with clear rationale, clinical logic, and NCLEX-focused insight to help you think and respond like a professional nurse. So, stay tuned till the very end, because this topic will not only boost your exam readiness, but also your ability to deliver safe, evidence-based care to clients with hematologic challenges. And always remember, at Stancoast NCLEX, we do not just prepare you to pass the exam. We prepare you to stand strong, think critically, and care compassionately. Let's begin this empowering session on bone marrow disorders.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get: 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us now move into a clinically focused question that connects pathophysiology, comfort care, and positioning principles. A client diagnosed with polycythemia vera reports increasing abdominal fullness and discomfort. Upon assessment, the nurse notes an enlarged spleen, known as splenomegaly. Now the question is, which position would promote the greatest comfort and ease of breathing for this client? The available options are as follows. Option 1 suggests sitting upright. Option 2 proposes lying supine. Option 3 recommends a lateral position. And Option 4 advises keeping the legs elevated. The correct answer here is Option 1, sitting upright. Polycythemia vera is a chronic myeloproliferative disorder characterized by excessive production of red blood cells, white blood cells, and platelets within the bone marrow. This abnormal overproduction causes increased blood viscosity and volume, which can lead to sluggish circulation, tissue hypoxia, and organ congestion. One of the most prominent complications is splenomegaly, where the spleen enlarges because it works excessively to filter out abnormal or excess blood cells. As the spleen expands, it pushes against other abdominal organs and exerts upward pressure on the diaphragm, resulting in discomfort, fullness, and difficulty breathing, especially when the client is in a flat position. Placing the client in a sitting upright or high Fowler's position uses gravity to draw the enlarged spleen downward, thereby reducing diaphragmatic pressure. This promotes optimal lung expansion, improves oxygenation, and alleviates abdominal tension, making breathing significantly easier. The upright position also reduces venous congestion and enhances comfort by relieving pressure from the enlarged organs. In contrast, lying supine increases the discomfort by allowing the spleen to push further upward against the diaphragm, making respiration more difficult. Similarly, the lateral position provides partial relief but does not effectively reduce pressure on the diaphragm. Elevating the legs may actually worsen the situation by shifting more blood volume toward the abdomen, heightening abdominal pressure and respiratory strain. Stancoast. Clinical insight. Before we conclude, it is essential to remember that when splenomegaly expands the abdomen, gravity becomes the nurse's greatest ally. Upright positioning allows the diaphragm to move freely, promoting comfortable and effortless breathing for the client. Cambrenex, high-yield NCLEX. Pearl. Finally, always prioritize positions that enhance diaphragmatic relief and oxygenation in clients with organ enlargement. In simple terms, upright means uplifted comfort. Let us move into another clinically significant NCLEX scenario that tests your understanding of hematologic disorders and thrombosis prevention. A client diagnosed with polycythemia vera is at high risk for thrombus formation due to excessive production of red blood cells. The question asks, which nursing intervention is most appropriate to prevent the formation of blood clots in this client? Here are the available options. Option 1 suggests administering diuretics as ordered. Option 2 recommends increasing the client's fluid intake. Option 3 advises restricting dietary sodium. And option 4 encourages the client to lose weight. The correct answer is option 2, increasing the client's fluid intake. To understand why, let us explore the expanded rationale. Polycythemia vera is a chronic myeloproliferative disorder in which the bone marrow produces excessive red blood cells, white blood cells, and platelets. This overproduction causes hyperviscosity, meaning the blood becomes thick and sluggish, predisposing the client to clot formation. The most effective nursing intervention to prevent thrombosis is to ensure adequate hydration. Increasing oral fluid intake expands plasma volume, dilutes concentrated blood cells, and lowers viscosity, allowing smoother flow through blood vessels. This directly decreases the risk of stasis, endothelial injury, and platelet aggregation, collectively known as Virchow's triad, the classic foundation of thrombus development. Encouraging the client to drink around 3 to 4 liters of water daily, unless restricted for cardiac or renal conditions, supports optimal circulation and helps prevent life-threatening complications like deep vein thrombosis, stroke, or myocardial infarction, which are common in polycythemia vera. Looking at the other options, administering diuretics, option 1, is incorrect because they remove fluid from the body, leading to dehydration and hemoconcentration, which can worsen blood thickness and clot risk. Restricting dietary sodium, option 3, may help in controlling hypertension, but does not play a role in reducing blood viscosity. Encouraging weight loss, option 4, is beneficial for long-term cardiovascular health, but is not a direct intervention to prevent clot formation. Before we conclude, let us connect this concept with a practical nursing perspective. Stancoast. Clinical insight. In polycythemia vera, water is the simplest anti-thrombotic therapy. Every sip thins the blood, improves circulation, and protects vital organs from ischemia. And now for your NCLEX mastery tip, NCLEX Pearl. Think H for hydration in polycythemia vera. Keeping plasma volume high prevents the thick blood from becoming a clotting hazard. Always teach clients to maintain fluid intake and avoid dehydration triggers like diuretics, alcohol, or excessive heat exposure. Moving ahead into another essential hematologic scenario, Let us explore the therapeutic approach to polycythemia vera. A client recently diagnosed with this condition has been informed by the physician that phlebotomy will be required as part of treatment. Later that day, the nurse evaluates the client's understanding of this prescribed therapy. The question asks, which client statement indicates accurate comprehension of the purpose and nature of this procedure? The available options are as follows. Option A says, blood will be removed from my vein to decrease its thickness. Option B states, I'll have tight tourniquets placed to help block the blood flow. Option C mentions, the doctor will close off some of my veins so they can't swell. And option D says, I'll be given a blood transfusion to improve my circulation. The correct answer is option A. Blood will be removed from my vein to decrease its thickness. To understand this more deeply, polycythemia vera is a chronic myeloproliferative disorder in which the bone marrow produces excessive red blood cells, white blood cells, and platelets, leading to hyperviscosity and sluggish circulation. This abnormally thick blood results in increased cardiac workload, poor tissue perfusion, and a high risk of thrombosis. Phlebotomy serves as the cornerstone treatment, aimed at controlling hematocrit levels and reducing blood viscosity. In this therapeutic procedure, approximately 500 to 2,000 milliliters of blood are removed through venipuncture, similar to a regular blood donation. By decreasing the number of circulating red blood cells, oxygen delivery to tissues improves, and the risk of complications such as stroke, myocardial infarction, or deep vein thrombosis is significantly reduced. Afterward, intravenous fluids are commonly infused to replace lost plasma volume and maintain hemodynamic stability. Phlebotomy sessions are often scheduled at regular intervals, typically every few weeks, until the hematocrit stabilizes below 45% in men and 42% in women. Now let us clarify why the remaining options are incorrect. Option B, which describes applying tight tourniquets to block blood flow, shows a misunderstanding of the purpose of phlebotomy. Tourniquets are briefly used to locate veins, not to obstruct circulation. Option C, which involves surgically occluding veins, is not only unrelated to polycythemia vera treatment, but would also endanger venous return and increase clot risk. Lastly, option D suggests administering a blood transfusion, which would worsen the hyperviscosity by further increasing red blood cell count, thereby heightening the likelihood of thrombotic events. Transitioning to a key professional insight, Stancoast. Clinical insight. Phlebotomy is therapeutic bloodletting, not for anemia correction, but for viscosity reduction. Each session resets the circulatory balance by lightening the blood's load and restoring smoother flow through every vital organ. Finally, to reinforce this knowledge, high-yield NCLEX Pearl. Think of phlebotomy in polycythemia vera as the opposite of transfusion. Instead of adding, we are removing. The goal is to thin the blood, prevent clots, and protect the heart, brain, and lungs from hyperviscosity damage. Let us now move toward another high-yield hematologic scenario that tests both pathophysiological reasoning and clinical interpretation. A nurse is caring for a client diagnosed with polycythemia vera. During the shift assessment, the nurse evaluates the client for complications associated with this disorder. Which clinical manifestation should the nurse interpret as a direct consequence of the disease process? The available options are as follows. Option A says angina, option B states dyspepsia, option C mentions dysuria, and option D lists anorexia. The correct answer here is option A, angina. To understand why this is correct, let us explore the concept in depth. Polycythemia vera is a chronic myeloproliferative disorder in which the bone marrow produces excessive red blood cells, white blood cells, and platelets. This overproduction increases blood viscosity and volume, resulting in sluggish capillary flow and predisposing the client to thrombotic and ischemic complications. Among these, angina, or chest pain, occurs when thick, viscous blood restricts coronary circulation and reduces oxygen delivery to the myocardium. Even in the absence of coronary atherosclerosis, the heart may experience ischemia as microthrombi form and obstruct blood flow. Clinically, this means that in polycythemia vera, tissue hypoxia arises not from a deficit of red blood cells, but from poor flow dynamics and reduced oxygen transport efficiency. The cardiac workload increases as the heart struggles to propel viscous blood through narrowed vessels, leading to ischemic pain, dizziness, or headache. Management includes therapeutic phlebotomy to reduce hematocrit, maintaining hydration to improve viscosity, and prescribing low-dose aspirin to minimize clot formation. Let us now clarify why the other options are not correct. Option B, dyspepsia, is incorrect because indigestion is not a defining symptom of polycythemia vera. Although blood congestion in abdominal vessels can cause mild discomfort, dyspepsia is usually linked to gastrointestinal issues like gastritis or reflux, not hematologic abnormalities. Option C, dysuria, is also incorrect. Painful urination is typically associated with urinary tract infections or renal stones, not with polycythemia vera. While renal thrombosis can occur in rare cases, it is not a common manifestation. Option D, anorexia, though possible in chronic illness, is not a primary sign of this disorder. More characteristic features include ruddy skin color, pruritus after warm baths, headaches, and thrombotic events due to hyperviscosity. Transitioning to a deeper clinical perspective, here comes the Stan Coast clinical insight. In polycythemia vera, the blood becomes a burden, thick, slow, and oxygen-poor despite its abundance. The heart struggles to pump this heavy fluid, producing ischemic chest pain as an early warning of danger. Recognizing angina promptly allows the nurse to intervene before complications such as myocardial infarction or stroke occur. Now moving toward the high-yield NCLEX Pearl. Think of polycythemia vera as the opposite of anemia: too many cells, too little flow. Angina results not from blocked arteries, but from sluggish circulation. Treatment focuses on reducing viscosity through phlebotomy, maintaining fluid balance, and protecting the client from clot-related emergencies. Let us now transition into an advanced hematologic scenario that tests your understanding of both anatomy and nursing procedure. A 67-year-old client is being evaluated for persistent pancytopenia, and the physician schedules a bone marrow aspiration to confirm suspected aplastic anemia. After the nurse explains the procedure and its purpose, the nurse asks the client to indicate where the specimen will be collected. Which anatomic site, if correctly identified by the client, indicates that teaching has been effective? Here are the options to consider. Option A states the posterior hip. Option B mentions the lower spine. Option C refers to the upper arm, and Option D lists the groin area. The correct answer is Option A, the posterior hip. To build a clear clinical picture, bone marrow aspiration is an essential diagnostic procedure that allows examination of hematopoiesis, cellular morphology, and marrow cellularity, crucial in conditions like aplastic anemia, leukemia, or myelodysplastic syndromes. The test involves withdrawing a small sample of the soft, spongy tissue from within bone cavities, where new blood cells are formed. In adults, the posterior iliac crest, located at the curved upper rim of the ilium in the hip region, is the preferred site because it contains a rich reservoir of active marrow, is easy to access, and minimizes the risk of injury to internal organs or major vessels. Moving deeper into clinical reasoning, it is important to note that while the sternum can serve as an alternate site, it is reserved strictly for aspiration, not biopsy, due to its proximity to the mediastinal structures. The lower spine poses a danger of spinal cord injury and offers limited marrow yield, while the upper arm bones are primarily cortical with little cancellous tissue, making them unsuitable. Similarly, the groin area, though vascular, lacks safe bony access points for marrow extraction. From a nursing care standpoint, the nurse prepares the client by explaining that local anesthesia will be administered, and that a sharp, brief pain may occur when the needle enters the bone. The nurse helps position the client, usually prone or side-lying, to fully expose the posterior iliac crest. After the sample is obtained, firm pressure is applied for 5 to 10 minutes to prevent bleeding, followed by a sterile dressing. Post-procedure care includes monitoring for pain, bleeding, or signs of infection, and instructing the client to report any fever, drainage, or persistent soreness at the site. Clinically, aplastic anemia represents bone marrow failure, where normal hematopoietic tissue is replaced by fat, leading to decreased production of red cells, white cells, and platelets. This explains the pancytopenia observed in laboratory reports and makes bone marrow aspiration the key confirmatory diagnostic step before initiating treatment such as immunosuppressive therapy or stem cell transplantation. Before we wrap up this discussion, here comes an insightful takeaway. Stancoast Clinical Insight. Think of the iliac crest as the bone marrow's gateway, broad, rich, and safely accessible. Its central role in diagnosis ensures accurate sampling while protecting the client from unnecessary procedural risk. And to reinforce this high-yield concept for your NCLEX preparation. High-yield NCLEX Pearl. When asked about bone marrow aspiration sites, remember the phrase, hip first, sternum second, never spine or limb. The posterior iliac crest provides both safety and reliability for evaluating hematologic disorders. Hey, wait a second. Before you scroll, I've got something that could totally transform your NCLEX journey.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us smoothly move into our next clinical scenario that blends technical precision with patient-centered care. During a bone marrow aspiration, the nurse's actions play a pivotal role in ensuring both safety and comfort for the client. The question asks, which nursing intervention best demonstrates the nurse's primary responsibility for client safety and comfort during the procedure? The options to consider are as follows. Option A suggests minimizing the client's discomfort through support and analgesia. Option B states holding the aspiration needle steady during sample collection. Option C includes regulating suction pressure on the collection syringe. Option D proposes administering supplemental oxygen during the procedure. The correct answer is Option A. Minimizing the client's discomfort through support and analgesia. Bone marrow aspiration is a diagnostic procedure in which marrow is withdrawn from the medullary cavity, typically from the posterior iliac crest, to assess hematopoietic activity, cellular morphology, or diagnose disorders such as leukemia, anemia, or pancytopenia. Although a local anesthetic is administered, the client still experiences a distinct pressure sensation and sharp pain when the needle penetrates the cortical bone. Therefore, the nurse's foremost responsibility is to alleviate both physical and emotional distress by pre-medicating with prescribed analgesics or mild sedatives, providing continuous reassurance and encouraging relaxation or deep breathing techniques. Throughout the procedure, the nurse must also monitor vital signs, maintain sterile technique, and apply firm pressure post-procedure for 5 to 10 minutes to prevent bleeding or hematoma formation. Shifting to the incorrect alternatives, option B is inaccurate because holding or manipulating the aspiration needle is the responsibility of the physician or a specially trained practitioner, not the nurse. The nurse's role is limited to positioning the client and ensuring a sterile field is maintained. Option C is also incorrect since suction regulation is not applicable here. Marrow is aspirated using a syringe, not a suction machine, and excessive force could traumatize cells or intensify the client's pain. Option D is not appropriate because oxygen administration is generally unnecessary unless the client has pre-existing respiratory impairment. The discomfort experienced during aspiration does not typically lead to oxygen desaturation. Stancoast. Clinical insight. Before diving into the technical details, always remember, comfort begins even before the needle touches the skin. The nurse's ability to anticipate pain, prepare the client mentally, and maintain calm communication transforms a stressful, invasive procedure into a safer, more trusting experience. Nursing excellence in procedures like bone marrow aspiration lies not only in skill, but in empathy. By explaining sensations, maintaining eye contact, and reinforcing safety, the nurse protects both body and mind. High-yield NCLEX, Pearl. Think of this as the golden rule of the bone marrow procedure. Posterior iliac crest is the gold standard site, and the nurse's gold standard responsibility is pain control and reassurance. After the aspiration, closely monitor for complications such as bleeding, infection, or persistent pain. Educate the client to avoid strenuous activity or heavy lifting for 24 hours and to report any increased swelling or drainage at the site immediately. Let us move forward with another critical post-procedure nursing scenario that focuses on safety and complication prevention. Following completion of a bone marrow aspiration procedure from the posterior iliac crest, the nurse must determine which post-procedure assessment is the most essential to ensure the client's safety. The options provided are as follows. Option A involves monitoring for fluctuations in blood pressure. Option B suggests assessing for bleeding from the puncture site. Option C focuses on observing for irregularities in heart rhythm. Option D refers to evaluating for an altered level of consciousness. The correct answer is Option B, assessing for bleeding from the puncture site. Bone marrow aspiration involves puncturing the cortical bone to withdraw marrow for diagnostic evaluation of hematologic disorders such as leukemia, anemia, and pancytopenia. Because the procedure penetrates highly vascular bone tissue, the most immediate post-procedure risk is bleeding from the puncture site, especially in clients with thrombocytopenia, coagulopathy, or bone marrow suppression. The nurse's foremost responsibility after the procedure is to apply firm pressure to the site for 5 to 10 minutes and to monitor closely for active bleeding, hematoma formation, or persistent pain. If bleeding occurs and is not controlled, a painful subcutaneous hematoma can develop, increasing the risk of infection and discomfort. In immunocompromised clients, even a small hematoma can become a site for bacterial colonization. Therefore, continuous assessment for bleeding is both a safety and infection prevention priority. In contrast, option A, monitoring for fluctuations in blood pressure, is not the primary concern unless significant hemorrhage occurs. Minor transient changes may occur due to anxiety, procedural pain, or stress, but they are not indicative of a complication. Similarly, option C, observing for heart rhythm irregularities, is not typically relevant because the procedure does not affect cardiac conduction pathways. Option D, evaluating for an altered level of consciousness, would only be appropriate if the client received sedatives or experienced hypovolemia. However, bone marrow aspiration is usually performed under local anesthesia, with the client awake and oriented throughout. Now shifting into an important professional insight for nurses, here comes your Stancoast clinical insight. After every invasive procedure, the nurse's eyes should go where the needle went. Continuous observation for bleeding, swelling, or drainage is the silent guardian of patient safety, especially in hematologic conditions where platelets are scarce. Finally, as we highlight the key learning high-yield NCLEX pearl, always maintain firm pressure and a sterile dressing over the aspiration site. Monitor vital signs and instruct the client to avoid strenuous activity for 24 hours. Report any persistent bleeding, increasing pain, or signs of infection immediately. The posterior iliac crest remains the gold standard site, but the nurse's vigilance is the gold standard of care. Let us now transition into an important clinical scenario that truly tests the nurse's ability to identify early signs of physiological distress during patient care. During a morning bath, a client recently diagnosed with aplastic anemia begins to appear uncomfortable. The question asks which nursing observation provides the most reliable indication that the client is experiencing difficulty tolerating the current level of activity. The options presented are option A, shortness of breath; option B, extreme nausea; option C, pulse of 60 beats per minute; and option D, moist and cool skin. The correct answer is option A, shortness of breath. To understand why, let us explore this in depth. Aplastic anemia, also known as bone marrow failure syndrome, occurs when the bone marrow is unable to produce sufficient red blood cells, white blood cells, and platelets. This results in pancytopenia, leading to anemia, leukopenia, and thrombocytopenia. Among these, the lack of red blood cells critically reduces oxygen-carrying capacity, making the client prone to exertional fatigue and hypoxia. When a nurse observes shortness of breath during light activity such as bathing, it is the most accurate and early indication that the cardiovascular and respiratory systems are failing to meet the body's oxygen demands. This sign should immediately prompt cessation of the activity, provide rest, and consider supplemental oxygen as needed. The nurse's care plan must emphasize energy conservation, clustering of care, and balancing activity with frequent rest periods to prevent hypoxemia and tissue oxygen debt. Now, analyzing the distractors, option B, extreme nausea, while possible due to fatigue or side effects of medications like immunosuppressants, does not directly indicate oxygen deprivation or activity intolerance. Option C, a pulse of 60 beats per minute, signifies bradycardia, which is not typical in aplastic anemia. Instead, the compensatory response would be tachycardia to increase oxygen delivery. Option D, moist and cool skin, may suggest hypertension or shock, but is not an early or primary sign of anemia-related exertional intolerance. Thus, shortness of breath remains the most reliable indicator of overexertion in this condition. Transitioning to the Stancoast clinical insight. When bone marrow fails, every breath counts. Nurses must understand that dyspnea during minimal activity in a client with aplastic anemia signals oxygen debt and must be treated as an early red flag. Prioritizing rest, promoting oxygenation, and strategically clustering care are key steps to prevent progression to hypoxemia or collapse. Moving forward to the high-yield NCLEX Pearl. Always think in terms of oxygen balance. In aplastic anemia, reduced red blood cell mass equals reduced oxygen transport. The first visible sign of overexertion is shortness of breath, not pallor or nausea. Effective nursing care revolves around pacing activity, conserving energy, and carefully monitoring for early hypoxia during all daily care routines. Moving forward into another insightful clinical scenario, a nurse conducting a routine assessment reviews a client's laboratory results and finds that the platelet count is only 45,000 per cubic millimeter. The question asks which clinical manifestation the nurse should expect to observe during the physical examination. The available options are Option A, multiple bruises on the extremities, Option B, pale skin color and conjunctiva, Option C, elevated body temperature, and Option D, cool, clammy extremities. The correct answer here is Option A, multiple bruises on the extremities. When platelet levels drop below 150,000 per cubic millimeter, this condition is termed thrombocytopenia, which greatly increases the risk of bleeding because of the body's inability to form stable clots. Once platelets fall under 50,000 per cubic millimeter, spontaneous bleeding can occur, particularly in the skin and mucous membranes. The nurse may notice petechiae, purpura, or ecchymosis, those classic bruises that appear mainly on dependent areas, like the arms and legs. These findings reflect capillary fragility and the body's failure to plug minor vascular injuries. Recognizing this is crucial because it signals the need for immediate bleeding precautions, such as avoiding invasive procedures, using a soft toothbrush, and monitoring for hidden bleeding in the stool or urine. In contrast, pale skin color and conjunctiva seen in Option B indicate anemia, which stems from low red blood cells or hemoglobin, not platelets. Option C, elevated body temperature, is more commonly linked to infection or dehydration, often seen in neutropenia. Lastly, Option D, cool and clammy extremities, usually suggest circulatory shock or hypoperfusion from severe blood loss, not directly caused by low platelet counts. Transitioning to the Stancoast clinical insight, think of platelets as the body's internal bandages. When they are low, even minor bumps can paint the skin with bruises. Thrombocytopenia makes even small injuries dangerous. The nurse must treat early skin changes such as petechiae, purpura, or bruises as red flags for potential internal hemorrhage. Gentle handling, vigilant monitoring, and strict adherence to bleeding precautions are essential to protect patient safety. Now, highlighting the high-yield NCLEX Pearl. Always interpret lab results through the lens of clinical findings. Low red cells cause fatigue and pallor, low white cells signal infection risk, and low platelets warn of bleeding dangers. For pancytopenic patients, assess which abnormality poses the most immediate threat. In thrombocytopenia, the bleeding risk, especially intracranial or gastrointestinal hemorrhage, takes top priority for nursing intervention. Let us move into this crucial infection control scenario that every nurse must master. You are caring for a client undergoing chemotherapy who now has a markedly reduced leukocyte count, a condition known as leukopenia. The question asks, which intervention should take top priority to prevent potentially life-threatening complications? Here are the options to consider carefully. Option A suggests performing thorough and consistent hand hygiene before and after client contact. Option B involves wearing a protective gown during direct care. Option C recommends applying direct pressure to all puncture sites following venipuncture. Option D proposes monitoring the client's heart rate and rhythm at least once per shift. The correct answer is Option A, performing thorough and consistent hand hygiene before and after client contact. Let us now understand why this option takes precedence. A client with leukopenia, especially when caused by chemotherapy, faces an extremely high risk of infection due to the severe reduction in white blood cells, particularly neutrophils, which are key defenders against bacterial invasion. In such an immunocompromised state, even ordinarily harmless microorganisms from the client's own skin or environment can lead to severe sepsis. Meticulous hand hygiene by healthcare workers, before and after every client interaction and after glove removal, is scientifically proven to be the single most effective strategy in preventing healthcare-associated infections. This simple action breaks the transmission chain of pathogens and directly saves lives. Because these clients often fail to exhibit typical signs of inflammation, such as redness, swelling, or pus, early detection of infection becomes challenging. Fever might be the only early indicator, which is why prevention must always come before detection. Additional measures like protective isolation, avoiding raw foods or flowers, restricting sick visitors, and using sterile technique for all invasive procedures further enhance protection. Yet, among them all, hand hygiene remains the cornerstone defense. Turning to the incorrect options for clarity, Option B, wearing a protective gown, can help reduce environmental contamination, but is not necessary unless there is a risk of splashing or direct exposure to body fluids. It serves as a supplement, not a substitute, for proper hand hygiene. Option C, applying direct pressure to puncture sites, is crucial for clients with thrombocytopenia, not leukopenia, since the concern there is bleeding rather than infection. Option D, monitoring the heart rate and rhythm, is essential for overall assessment, but does not contribute to infection prevention in leukopenic clients. Now for the Stancoast clinical insight. Leukopenia turns even the smallest germ into a major threat. The nurse's clean hands become the client's first line of defense against invisible invaders. And here comes high-yield NCLEX Pearl. Always prioritize prevention before detection in leukopenic clients. Maintain strict aseptic practices, avoid unnecessary invasive procedures, and report any fever immediately. Remember, clean hands are not just professional. They are life-saving for immunocompromised clients. Let us now move into a highly relevant communication and client education scenario that often appears on the NCLEX. A client scheduled for elective surgery expresses anxiety, saying, "I am afraid to receive a blood transfusion because I might get HIV." The nurse must choose the most accurate and therapeutic response that reflects both scientific accuracy and empathy. Here are the options to consider. Option A states, blood donors are tested for HIV before their blood is accepted. Option B asserts, donated blood no longer contains the HIV virus. Option C explains, donated blood is tested for HIV antibodies after collection. Option D declares, there is no way to identify the AIDS virus in blood yet. The correct answer is Option C. Donated blood is tested for HIV antibodies after collection. When breaking this down further, the rationale lies in understanding modern transfusion safety. Since 1985, all donated blood has been rigorously screened for HIV-1 and HIV-2 antibodies, the HIV-P24 antigen, and through nucleic acid amplification testing, NAT. These layered procedures make the blood supply extraordinarily safe, with the risk of HIV transmission now estimated at only 1 in 1.5 to 2 million transfusions. Despite this, a slight window period remains, the brief interval between infection and the detectability of viral markers, meaning no system is entirely risk-free. To further enhance safety, donors also undergo extensive behavioral screening regarding drug use, sexual practices, and exposure risks. Therefore, the nurse must reassure the client truthfully, blood is highly safe due to testing, but not absolutely risk-free, thereby fostering informed consent and trust through honesty and transparency. Moving to the analysis of incorrect responses, Option A is incorrect because actual HIV testing is performed on collected blood samples, not on donors themselves. Pre-donation screening relies on questionnaires and physical assessments but not laboratory testing before collection. Option B is also incorrect because it conveys false reassurance. Modern blood is very safe, but it cannot be said to no longer contain HIV completely, as there remains a minuscule risk. Option D is outdated and scientifically inaccurate, as multiple highly sensitive methods, including enzyme-linked immunosorbent assay, ELISA, and NAT, can now detect HIV in blood effectively. Transitioning now to our Stancoast clinical insight, remember that the safest blood is never assumed. It is continuously screened, tested, and ethically donated. Nurses play a vital role in educating clients that modern transfusion practices combine science, ethics, and vigilance to protect every recipient. Finally, as part of our high-yield NCLEX Pearl, keep this essential fact in mind. All donated blood undergoes mandatory post-collection testing for HIV, hepatitis B and C, syphilis, and other transfusion-transmissible infections. The risk of contracting HIV from a transfusion today is exceptionally rare, but nurses should always communicate both safety measures and residual risks clearly to maintain client confidence and support informed decision-making. Let us move forward into a clinically relevant transfusion scenario that beautifully integrates both pathophysiology and patient education. A nurse is preparing to administer a transfusion of packed red blood cells to a client with symptomatic anemia and mild congestive heart failure. The client curiously asks, how are packed red blood cells different from the usual blood transfusion? Now, this is a perfect opportunity for the nurse to provide both accurate and therapeutic education that reinforces client trust. The options are as follows. Option A states that packed red blood cells contain the same amount of red blood cells but in less plasma volume. Option B explains that packed red blood cells contain more red blood cells suspended in the same amount of plasma. Option C claims that packed red blood cells are specially treated to prevent allergic reactions. Option D asserts that packed red blood cells help stimulate the bone marrow to produce new red blood cells. The correct answer is option A, which says that packed red blood cells contain the same amount of red blood cells, but in less plasma volume. This response is scientifically accurate and reflects safe nursing practice. Packed red blood cells, commonly referred to as PRBCS, are derived from whole blood by removing nearly 2/3 of the plasma. Each unit of PRBCs contains approximately the same number of red blood cells found in a unit of whole blood, but within a reduced volume, typically around 250 to 300 milliliters. This concentrated form of transfusion is particularly vital for clients with anemia who also have heart failure or renal impairment, as it corrects oxygen-carrying deficits without overloading the circulatory system. The concept behind this is component therapy, where only the specific component needed by the patient is transfused, ensuring effectiveness while minimizing complications like fluid overload, electrolyte imbalance, and immune reactions. Moving on to why the other options are incorrect. Option B is inaccurate because PRBCs do not contain more red blood cells than whole blood. They contain the same number, but within less plasma. The term packed often confuses learners. It refers to the concentration of cells, not an increase in quantity. Option C is also incorrect because PRBCs are not specially treated to prevent allergic reactions. Allergic responses are linked to plasma proteins, and since PRBCs contain minimal plasma, the risk is naturally reduced, but not entirely eliminated. In clients with repeated transfusion reactions, washed red blood cells, where almost all plasma is removed, may be indicated instead. Option D is incorrect as well because transfused PRBCs do not stimulate the bone marrow to produce new cells. Bone marrow stimulation occurs physiologically in response to hypoxia or pharmacologically via erythropoietin therapy, not through transfusion. Before we conclude, let us pause for a deeper takeaway. Stancoast. Clinical insight. Component therapy transforms transfusion from a one-size-fits-all practice into a precise, targeted intervention, delivering what the client needs while protecting against what they do not. And to reinforce this further, high-yield NCLEX Pearl. When caring for anemic clients with heart failure, packed red blood cells are always preferred over whole blood because they deliver oxygen efficiently while avoiding fluid overload. During transfusion, nurses must vigilantly monitor for reactions, track the client's fluid status, and assess for signs of circulatory overload, such as dyspnea, crackles, and jugular venous distension. Hey friend, pause for just a sec. I've got something amazing for you.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Moving into a critical transfusion scenario, imagine a nurse preparing to administer a unit of blood to a client whose blood type is A, Rh positive. The question asks, which of the following blood types must the nurse refuse to administer, knowing that it would lead to an acute hemolytic transfusion reaction? Let us look closely at the available options. Option A is type A, Rh negative. Option B is type O, Rh positive. Option C is type O, Rh negative. Option D is type AB, Rh positive. The correct answer here is option D, type AB, Rh positive. This is because transfusing blood that contains antigens against which the recipient's plasma has antibodies can trigger an immediate and potentially fatal immune reaction. Individuals with type A, Rh positive blood have A antigens on their red blood cells and anti-B antibodies circulating in their plasma. If blood from a donor with type AB, Rh positive blood is given, the B antigens on those donor cells will react with the recipient's anti-B antibodies. This immune reaction results in the rapid destruction of donor red blood cells, a process known as intravascular hemolysis. The released hemoglobin can clog renal tubules, leading to acute kidney injury, and may also precipitate disseminated intravascular coagulation, hypotension, and cardiovascular collapse within minutes, if not recognized promptly. To explain further, transfusion compatibility is determined by both the ABO and Rh systems. Type A individuals can receive type A or type O blood, since type O blood lacks A or B antigens and is therefore the safest universal donor for red cells. Rh-positive individuals, on the other hand, can receive either Rh-positive or Rh-negative blood because they already possess the D antigen and will not develop anti-D antibodies. However, receiving any blood type containing B antigens, such as type B or type AB, will cause a hemolytic reaction due to the presence of anti-B antibodies in their plasma. Let us carefully evaluate each choice. Option A, type A, Rh negative, is compatible because it has the same ABO type and lacks the Rh factor, posing no threat to an Rh positive recipient. Option B, type O, Rh positive, is also compatible, as type O blood lacks both A and B antigens, eliminating the risk of ABO incompatibility. The Rh positive factor is safe for Rh positive clients. Option C, type O, Rh negative, is universally compatible and often used in emergencies since it has neither AB antigens nor the Rh factor. Option D, type AB, Rh positive, is incompatible because it contains both A and B antigens, and the presence of B antigens triggers an immune-mediated hemolytic response in a type A recipient. Stancoast. Clinical insight. Transfusion safety begins before the blood ever leaves the bank. Nurses serve as the final checkpoint, ensuring that ABO and Rh compatibility is verified. This vigilance prevents one of the most fatal transfusion errors, the acute hemolytic reaction. High-yield NCLEX Pearl. Always carry out a 2-nurse verification before transfusion, confirming the blood type, Rh factor, and crossmatch. Once transfusion starts, monitor for the earliest warning signs of a hemolytic reaction: fever, chills, chest tightness, back pain, hypertension, and dark urine. If any of these occur, stop the transfusion immediately, maintain intravenous access with normal saline, and promptly notify the physician and the blood bank. Let us now move to a critical nursing scenario that requires immediate clinical judgment. During the first 15 minutes of a blood transfusion, the nurse must stay alert for any sign of an acute transfusion reaction. The question asks, which assessment finding most strongly indicates that the client is developing such a reaction? Here are the options. Option A. The client feels an urgent need to urinate. Option B. The client's blood pressure drops significantly. Option C. The client has localized swelling at the infusion site. Option D. The client's skin appears pale around the infusion site. The correct answer is option B. The client's blood pressure drops significantly. A sudden and notable decrease in blood pressure during the first 15 minutes of a transfusion is a hallmark indicator of an acute hemolytic transfusion reaction, the most severe and potentially fatal type. This medical emergency occurs when donor red blood cells bearing incompatible antigens are destroyed by the recipient's pre-existing antibodies, commonly anti-A or anti-B, in ABO incompatibility or anti-Rh in sensitized Rh-negative clients. As these antibodies attack, they trigger the complement system, causing rapid intravascular hemolysis. The resulting release of hemoglobin, bradykinin, and inflammatory cytokines produces profound vasodilation, increased capillary permeability, and subsequent hypertension. In parallel, the kidneys become overwhelmed by free hemoglobin, leading to decreased urine output and potential acute tubular necrosis, placing the client at risk for acute kidney injury if the transfusion is not immediately stopped. These symptoms typically emerge within 10 to 15 minutes of transfusion initiation and may include fever, chills, anxiety, back or flank pain, dyspnea, tachycardia, hypertension, and hemoglobinuria. For this reason, nurses must remain at the bedside for the first 15 minutes. Infuse blood slowly, no faster than 2 milliliters per minute, and closely monitor the client's vital signs and appearance. If hypotension or any other suspicious symptom develops, the transfusion must be stopped immediately. The nurse should maintain IV access with normal saline using new tubing, notify the physician and blood bank, save the blood bag and tubing for testing, and collect blood and urine samples to confirm hemolysis. Early intervention with intravenous fluids, diuretics, and vasopressors can prevent irreversible complications such as shock or renal failure. Moving on to why the other options are incorrect. Option A, the client's urgent need to urinate, is not characteristic of transfusion reactions. In fact, urine output usually decreases due to hemoglobin-induced kidney injury. Option C, localized swelling at the infusion site, reflects infiltration or extravasation rather than a systemic reaction. It points to a mechanical issue with IV access, not an immunologic process. Option D, pale skin around the infusion site, is non-specific and may simply result from local cooling or vasoconstriction, not a transfusion-related reaction. Now moving into the Stancoast clinical insight. The first 15 minutes of a transfusion are the most dangerous. Continuous presence, vigilance, and rapid recognition of subtle changes, especially a falling blood pressure or back pain, can be the difference between recovery and catastrophe. And finally, the high-yield NCLEX pearl. Always remain with the client for the first 15 minutes, administer the blood slowly, and monitor vital signs closely. At the first sign of hypotension, fever, or chills, stop the transfusion immediately and maintain normal saline through new tubing. Quick action during these early moments can protect the kidneys and save lives. Let us now transition into a clinically rich scenario that evaluates the nurse's understanding of corticosteroid therapy and its systemic effects. A 52-year-old client with a known autoimmune disorder reports being on long-term corticosteroid treatment for over 1 year. During the physical examination, the nurse must determine which assessment finding is most likely associated with chronic corticosteroid use. Here are the options to consider. Option A suggests that the client's voice is quite husky. Option B indicates that the client's face appears moon-shaped. Option C states that the client's muscles are well developed and large. Option D proposes that the client's skin appears tanned and bronzed. The correct answer is Option B. The client's face appears moon-shaped. Long-term corticosteroid therapy leads to the development of distinct physical characteristics that mimic the manifestations of Cushing's syndrome. One of the hallmark features is the moon face, which presents as a round, full, and puffy face due to abnormal fat deposition. Chronic glucocorticoid exposure causes a redistribution of adipose tissue from the limbs toward the trunk, neck, and face, producing the characteristic facial rounding, central obesity, and buffalo hump on the upper back. This results from prolonged stimulation of glucocorticoid receptors, leading to fat storage in specific regions and catabolism in others. Prolonged steroid therapy also suppresses the hypothalamic pituitary adrenal axis, leading to a state of secondary Cushingoid appearance. Other associated manifestations include fragile, thin skin, purple abdominal striae, easy bruising, poor wound healing, hyperglycemia, hypertension, osteoporosis, and susceptibility to infection due to immunosuppression. Psychologically, clients may display irritability, mood swings, or steroid-induced psychosis. Nurses must be vigilant in identifying these complications early and in educating clients about the risks of prolonged steroid use. It is also vital to understand that corticosteroids should never be stopped abruptly, as sudden withdrawal after long-term therapy can trigger life-threatening adrenal insufficiency marked by severe hypotension, fatigue, and electrolyte imbalance. Now, let us analyze why the other options are incorrect. Option A, the client's voice is quite husky, is not related to corticosteroid effects. This symptom more likely suggests laryngeal irritation, thyroid pathology, or vocal cord inflammation. Option C, the client's muscles are well developed and large, is also incorrect because corticosteroids promote protein breakdown, leading to muscle wasting, particularly in the proximal muscle groups such as the hips and shoulders, resulting in weakness rather than hypertrophy. Finally, option D, the client's skin appears tanned and bronzed, is inconsistent with corticosteroid excess. Such pigmentation is a classic feature of Addison's disease, caused by cortisol deficiency and excessive adrenocorticotropic hormone stimulation of melanocytes. In corticosteroid excess, however, the skin becomes pale, thin, and fragile, with a tendency toward bruising rather than tanning. Stancoast. Clinical insight. Here comes a crucial takeaway. Long-term corticosteroid therapy transforms the body's natural feedback system into a suppressed, vulnerable state. Nurses play a key role in balancing therapeutic benefits with vigilant monitoring for Cushingoid features, infection, hyperglycemia, and adrenal suppression. High-yield NCLEX Pearl. Furthermore, always assess clients on chronic steroids for classic Cushingoid signs such as moon face, buffalo hump, truncal obesity, thin skin, and muscle wasting. Reinforce patient education on never discontinuing corticosteroids abruptly, taking them with food to prevent gastric irritation, and promptly reporting any mood changes, fever, or signs of infection. Moving ahead into our next clinical scenario, let us analyze a situation involving corticosteroid complications. A 54-year-old client with rheumatoid arthritis has been on long-term corticosteroid therapy for the past 8 months. During a routine assessment, the nurse must determine which client statement most strongly alerts to a potential corticosteroid-related complication. Here are the options to consider. Option A says, "I have been having frequent heartburn lately." Option B mentions, "I have been feeling sleepy in the afternoons." Option C notes, "I am not as hungry as I used to be." And option D adds, "My urine seems lighter in color these days." The correct answer is option A. "I have been having frequent heartburn lately." Corticosteroids, such as prednisone or methylprednisolone, increase gastric acid secretion while reducing the protective mucus barrier in the stomach. This imbalance predisposes the client to gastritis, gastric erosion, and peptic ulcer disease, which are among the most frequent gastrointestinal complications of chronic steroid use. Heartburn or epigastric discomfort is often an early warning sign of mucosal irritation or ulcer formation. If ignored, this can progress to gastrointestinal bleeding or perforation, manifesting as black tarry stools, melena, vomiting of blood, hematemesis, or severe abdominal pain. Therefore, nurses must recognize this as a red flag and advocate for protective measures such as proton pump inhibitors or histamine 2 receptor blockers. In addition, prolonged corticosteroid therapy inhibits collagen synthesis and delays tissue repair, which further slows ulcer healing. Combining steroids with non-steroidal anti-inflammatory drugs, NSAIDs, or alcohol greatly magnifies this risk. Hence, clients should always be instructed to take corticosteroids with food or milk, avoid NSAIDs and alcohol, and promptly report gastrointestinal symptoms like heartburn or abdominal pain. Now let us reflect on why the other options are incorrect. Option B, "I have been feeling sleepy in the afternoons," describes mild fatigue that is not typical of steroid therapy. In fact, corticosteroids are known to cause restlessness, insomnia, and mood swings rather than drowsiness. Option C, "I am not as hungry as I used to be," contradicts the usual effects of steroids, which tend to increase appetite and lead to weight gain due to fluid retention and altered fat metabolism. Option D. My urine seems lighter in color these days, does not indicate a steroid complication because pale yellow urine is normal. Steroids do not change urine color unless complications such as steroid-induced diabetes or kidney issues arise, which would present as increased urination rather than lighter hue. Transitioning to deeper understanding, Stankost. Clinical insight. Every dose of corticosteroid protects one system, but silently stresses another. Vigilant monitoring for gastric distress, blood glucose fluctuations, mood alterations, and infection risk turns routine nursing care into truly life-saving practice. Finally, the high-yield NCLEX pearl to remember. Always administer corticosteroids with meals, watch for warning signs of gastrointestinal bleeding such as black stools, and instruct clients to avoid alcohol or NSAIDs. When therapy extends beyond a few weeks, co-prescribing proton pump inhibitors or histamine. 2 blockers becomes an essential step to minimize ulcer risk and protect gastric health. Let us now shift our attention to a highly critical scenario in hematology that every nurse must master for both the NCLEX and clinical practice. Imagine a client diagnosed with aplastic anemia who has not responded to corticosteroid therapy and is now scheduled for a bone marrow transplantation following total body irradiation. The nurse understands that total body irradiation completely destroys the client's bone marrow, resulting in profound pancytopenia before the transplanted marrow begins to engraft. The key question is, during this extremely vulnerable period, what is the highest nursing priority for the client immediately before and for several weeks after the bone marrow transplantation? Here are the options to consider. Option A is relieving depression, Option B is promoting nutrition, Option C is preventing infection, and Option D is monitoring hydration. The correct answer is Option C, preventing infection. Following total body irradiation, the client experiences complete destruction of the bone marrow, leading to a period of total bone marrow ablation. This means that all blood cell lines, including white blood cells, red blood cells, and platelets, are wiped out. As a result, the client becomes profoundly neutropenic, often with an absolute neutrophil count below 500 per cubic millimeter. In this state, the client's immune defenses are virtually non-existent, placing them at extreme risk for opportunistic and life-threatening infections. Even microorganisms that are normally harmless, such as the normal flora of the skin, mouth, and intestines, can turn pathogenic. The critical time between bone marrow ablation and engraftment is the most immunocompromised period of the client's life. Because of this, the nurse's top priority must be to prevent infection through rigorous infection control measures. Strict protective isolation, meticulous aseptic technique, and environmental control are essential. Clients are typically placed in HEPA filtered rooms, and all staff and visitors must adhere to strict hand hygiene, wear gloves and masks, and minimize unnecessary exposure. Visitors are often limited, and all fresh flowers, fruits, and unpasteurized foods are restricted to prevent microbial contamination. The nurse should also monitor the client's temperature daily, assess for even the most subtle signs of infection such as sore throat, cough, or burning on urination, and promptly report any fever, even a low-grade one, since it could indicate sepsis. In addition, prophylactic antibiotics, antifungals, and antivirals are often prescribed to minimize infection risk until engraftment occurs. While the other options are important aspects of holistic care, they are not as critical as infection prevention during this stage. Addressing depression is important for emotional well-being, but does not pose an immediate threat to life. Promoting nutrition aids recovery, but cannot protect against the fatal complications of infection. Monitoring hydration supports renal and circulatory function, but is not the top priority in preventing mortality at this phase. Now, moving into the Stan Coast clinical insight. In bone marrow transplant clients, infection is the invisible enemy. Small lapses in hand hygiene or isolation technique can have fatal outcomes. The nurse becomes the client's immune system until engraftment occurs. Transitioning to the high-yield NCLEX pearl. After total body irradiation and before engraftment, neutropenia is at its peak. Always prioritize infection prevention above all other physiological or psychosocial needs. Remember this crucial sequence for your exam and practice: irradiation, pancytopenia, neutropenia, infection risk. Even a single febrile episode in a neutropenic client demands immediate medical evaluation and broad-spectrum antibiotic coverage. Thank you for watching. We will see you soon in next video.